Good morning. I'm Dr. Vaishali Gaikwad, Professor of Surgery, and I'm going to talk on enhanced recovery of the surgeon or ERAS. Wishing you speedy recovery or get well soon. This is what every relative or patient visiting a patient in the hospital wishes, and so does the surgeon. The ERAS protocols are a pathway towards this objective. First implemented by Professor Kerr, he described a pathway or for accelerating recovery in 2000. This is also called as fast track surgery. The recommendations and protocols are incorporated into a program which became the ERP or the Enhanced Recovery Program. And this was implemented by Farram et al. In 2005. ERAS is a patient-centered, multidisciplinary, evidence-based approach to a patient. It is a teamwork. The surgeon, anesthetist, intensivist, nurses, dietitians, physiotherapists all work towards a common goal of enhancing the recovery of the patient. ERAS is a goal-directed program aiming at reducing the surgical stress with minimum deviation from normal physiological function. If implemented successfully, ERAS has reduced the length of hospital stay by almost 30 to 40%. Also, the rate of complications are reduced. There are three distinct phases in the implementation of ERAS: the preoperative or the pre-hospital phase, the perioperative or intraoperative phase, and the postoperative phase. Every phase has a distinct set of protocols which evidence has shown to enhance recovery. Both the patient and the family must be given a very clear idea of what they're going to be expected in the pre-hospital phase. If the patient is a smoker, he or she must stop smoking. Alcohol should be withdrawn, and a proper diet should be maintained in the preoperative period. Family must be around to play a supporting role. The pain threshold of every patient is different, and therefore pain management should be discussed with the patient. The goal is a patient-centric analgesia. Prehabilitation. We have shifted from rehabilitation to prehabilitation. And prehabilitation is a form of strength training exercises to endure pain after surgery. It is easier for the patient to bear pain if he has a knowledge about it. And exercises which are to be done in the postoperative period, if they are taught in the preoperative period, the patient compliance is quite enhanced. In the perioperative period, it is imperative to see the limitations, to see the interventions. Surgery produces stress, which leads to increased metabolic demand and nitrogen consumption. Patient is in a catabolic phase. Carbohydrate loading decreases postoperative insulin resistance and a negative nitrogen balance. Many hospitals now advocate admission on the day of surgery. This also reduces the risk of hospital-acquired infections. Bowel preparations, which were recommended judiciously in for colonic surgery, are now almost given up, or if required, given on the day of surgery. Perioperative care started with the minimizing of the insult of surgery. With the advent of laparoscopic surgery, wounds are now much smaller, and access to parts of the abdomen that were previously requiring large incisions can now be accomplished by keyhole surgery. The era where big surgeons took big incisions now belongs to surgeons who take small incisions or no incisions at all. But this does not mean that surgeries not done laparoscopically are excluded from the program. Anesthetists play a major role in the team. They are the ones who administer analgesia. Also, in addition to anesthesia, the patient-controlled analgesia is a concept which is brought forward in ERAS. The aim is for a comfortable patient postoperatively who is able to return to function rapidly. Nasogastric drainage should be avoided, so do all catheters and drains, or if needed to be put, have to be removed at the earliest. Adequate pain relief, early feeding, and early mobilization are the cornerstones of ERAS, and discontinuation of IV fluid should be done as soon as feasible. The patient should be encouraged to sit in bed on the day of surgery and be out of bed on the first postoperative day itself. Watch for IES though. Discharge the patient as early as possible and with proper instructions on rehabilitation. Keep in touch with telephonic updates to a specialist nurse or the assistant. But why implement ERAS? ERAS has shown a distinct set of advantages. It improves the patient satisfaction, reduces the hospital stay without increasing the readmission rate. Significantly fewer surgical complications like anastomotic leak as well as non-surgical complications like nosocomial infections are seen, and early return to work is also observed. This all translates in reduction of cost of care. Implementation of ERAS is beneficial to the institute as well. It means a structured approach to the patient. It is not operator dependent. All the protocols are available to the staff at all the times. Early discharge means the institute is able to serve more patients within the infrastructure available. It is a teamwork, so the responsibility of the patient is shared by the team. And feedback from the team members is important in increasing the efficacy of the program. What are the differences between conventional teaching and the ERAS? Conventional teaching was to fast the patient overnight before surgery, give bowel preparation, and to overload with fluids. All these have been replaced in ERAS, backed by good evidence and change for the change for protocol. We now advocate overloading the patient with carbohydrates 2 hours prior to surgery. A minimum or a maximum of 6 hours of fasting is all that is necessary for a patient to be taken after surgery. Bowel preparations are done away with, and preoperative are given by choice. Preoperative antibiotics are given by choice. In the operative period also there is a paradigm shift. The cases which were doing under general anesthesia can now be done under regional anesthesia, or regional anesthesia is vocated for certain surgeries. All indwelling catheters are kept to a minimum. If a good peripheral line is possible, no central line or arterial lines are inserted. The fluid therapy is goal directed. Overloading of fluids to the patients is avoided at all costs. In the postoperative period, conventionally, Rayleigh tube was removed only after the patient passes motions, ensuring that good bowel movement is available or has started. ERAS forces early mobilization and feeding. Rayleigh tube catheters are all removed before they cause any harm. Early mobilization is the cornerstone of enforcing ERAS. But implementation of these protocols face a lot of challenges. Breaking away from the doctrine of surgery is difficult. Doubts, larger than life expectancies from the patients' attitudes, and cooperation in following the program are all imperative to this. We need to understand the needs of the patients, the expectations of the patients. We need to teach them the patients. Health literacy is an important object. The personal history of the patient, his attitudes and behavior also do matter. The staff also needs to be catered to the needs of the patients. The staff needs to be continuously encouraged to be constantly engaged with the patient. Skills and competence should be regularly upgraded and appraised. The specialty itself will benefit from a good leadership. Educating the staff and optimizing staff privileges is also important in taking up the ERAS program. ERAS is a continued pathway. The data should be periodically analyzed and new guidelines should be implemented. Development of ERAS. In conclusion, development of ERAS has highlighted the importance of perioperative care. The ability to reduce hospital stay, achieve patient satisfaction, reduce complication rate have demonstrated how powerful a tool ERAS is. ERAS has become a routine reality, and it is in the best interest of all to be familiar with ERAS and its principles. Thank you.